A few months ago, I was reviewing some medical case files from Europe, and I came across an interview with a physician that completely unmoored me. He wasn't some cold, clinical figure. In fact, his voice was filled with this profound, gentle warmth. He was talking about a young patient of his, a guy in his early 20s with autism. The doctor described how this young man struggled to make friends, felt utterly crushed by the social isolation of the modern world, and just couldn't keep up with the pace of society. With an almost serene, proud expression, the doctor explained how he finally alleviated that suffering. He sat by the bed, held the young man's hand, and administered a lethal injection. To this doctor, it was the ultimate act of mercy. He felt a deep-down satisfaction, genuinely believing he had done something beautiful. But then things took a jarring turn. The interviewer asked if they had tried changing the kid's environment or providing intensive social support to combat the loneliness before jumping to a permanent solution. The doctor's face immediately changed. He looked confused, even slightly annoyed, and completely switched his tune. He brushed it off, arguing that the patient had met the legal criteria for unbearable suffering, and that reshaping society wasn't his job. That instantaneous shift from a place of professed medical love to a clinical apathy about actually helping the guy live honestly left me stunned. The contradictory attitude that the most advanced, compassionate response to a vulnerable person feeling excluded by society is to simply help them exit it makes you realize something terrifying. We often warn about the slippery slope of medical ethics, but when you look at what's legally happening right now, you realize we aren't just approaching the edge. We've already slipped. Wow.
Yeah. I want to take you to a kitchen in Utrecht. The table was just too clean. A man named Willem is sitting there looking down at this medical assessment form resting on the surface. Right. The blue ink of his wife's signature is already dry on the page. And upstairs, their 15-year-old son, Lucas, is sitting in a bedroom that has been meticulously stripped of everything. No sharp objects, nothing heavy. Anything that could be turned into a weapon against himself is gone.
Just a completely barren room.
Exactly. Lucas is up there right now, just listening to the relentless Dutch rain drumming against the glass. For 3 agonizing years, his mind has been a burning house.
Refractory depression, right?
Yeah, that's what the psychiatrist called it, refractory. And for those listening, you have to understand that this isn't just a severe bout of sadness. Medically, it means treatment resistant. It's this inescapable inferno that no SSRIs, no electroconvulsive therapy, no intensive interventions could quench.
It's an incredibly heavy diagnosis for a kid that young. And under the law, a boy his age, caught in that blaze, could ask for peace. He could ask to be let out. But he needed Willem's hand to open the door.
He needed his father's consent.
Right. So Willem picks up the pen. His thumb traces the calloused ridge near his knuckle, the exact same spot where he used to hold Lucas's tiny hand to steady him when he was teaching him to ride a bike down those cobblestone streets.
Oh, man, breaking. The medical guidelines, the glossy brochures, the doctors, they all framed this parental consent as the ultimate act of protective love, the final shield a father could offer.
But it's a paradox, isn't it?
Really? Because as the nib of the pen touches the paper, the room just feels entirely hollow. Willem realizes that the system hadn't offered a cure for his boy. It had merely outsourced the bureaucracy of despair to a father's trembling hand.
What's fascinating here is the precise legal architecture that places a father like Willem in that agonizing position in the first place. To understand how a 15-year-old can legally request death, you have to look deeply at the Dutch framework, which is the Termination of Life on Request and Assisted Suicide Act.
Exactly. And if you were to open the Dutch criminal code right now, you'd actually see that euthanasia and assisted suicide are technically criminal offenses. They're explicitly outlawed.
Really? So the baseline is that it's illegal?
Yes. The foundational premise is that taking a human life is illegal. But the legal architecture provides this massive, highly structured exception. It effectively transforms a criminal act into a medical procedure. Well, the law exempts a physician from criminal liability, meaning no prison time, if they satisfy 6 strict statutory due care criteria.
Okay, I want to break these down for everyone listening because these criteria are essentially the only guardrails keeping the system from just collapsing into arbitrary death.
You can picture these criteria as a sequence of locked doors. The first door is the request itself. The doctor has to be absolutely satisfied that the patient's request is voluntary and well-considered.
Meaning no external pressure from tired family members.
No coercion, no temporary psychiatric delusion. The second door, and this is arguably the most complex, is the suffering. The physician must be convinced that the suffering is unbearable with no prospect of improvement.
But unbearable suffering is entirely subjective. There's no blood test or MRI scan that measures unbearable.
Exactly. It relies heavily on the patient's own articulation of their lived experience. And the no prospect of improvement part requires a medical consensus that all viable options are exhausted.
Which explains Lucas's case. The psychiatrists threw their hands up and declared the depression inextinguishable.
Precisely. Now, the third criterion is that the patient must be fully informed about their prognosis. They have to truly comprehend their reality.
And fourth,
The fourth is that both the doctor and the patient must independently conclude there's no reasonable alternative. And reasonable is the operative word there. If a theoretical treatment exists but has massive risks and low success rates, the patient isn't legally forced to endure it.
Okay, so they can say no to terrible side effects.
Right. Then the fifth criterion is the systemic check. An independent physician must be consulted to verify all these conditions in writing. They have a network for this in the Netherlands called SANIEN.
So a second set of eyes on the case.
Yes, an independent evaluation. And finally, the sixth criterion mandates that the termination itself must be executed with due care, adhering to established pharmacological protocols.
So that seems pretty rigorous on paper when you're talking about an adult with terminal cancer, but we're talking about minors here. You're applying this exact same framework to children.
Yes, and that is where it introduces this terrifyingly complex layer of developmental assessment. Under Dutch law, children as young as 12 can legally request euthanasia.
12? That's middle school. Yeah.
But the bureaucratic requirements shift based on age. For a teenager between 16 and 17, the parents must be involved in the consultation process. But incredibly, from a legal standpoint, the parents' actual consent is not required.
Wait, a 17-year-old can proceed with state-sanctioned death even if their parents are begging them not to?
Yes. The parents can object, but they don't have veto power at 17.
That is a staggering level of autonomy granted to a minor.
However, for a child aged 12 to 15, like Lucas, the law recognizes a lesser degree of autonomy. For this younger cohort, the euthanasia can only be carried out with the explicit written consent of the parents.
So the child initiates the request, but the parent holds the final key.
Exactly. And you have to understand, this framework is not static. It's actively expanding. Recently, the Dutch government backed a move to allow euthanasia for terminally ill children between the ages of 1 and 12.
1 to 12.
Yes. The health minister argued this was a necessary evolution of compassion to prevent hopeless suffering. And interestingly, they aren't pushing to change the primary parliamentary law outright.
So how are they doing it?
They're implementing a ministerial regulation that exempts doctors from prosecution if they euthanize a child in that 1 to 12 bracket, provided strict protocols are met. They're effectively legalizing it through prosecutorial discretion.
Yes. If you are sitting at home, I want you to really think about the neurobiology of what is being asked of these children.
It's a heavy thing to consider.
How can a legal system or a medical board genuinely evaluate a 12-year-old's reasonable understanding of their own best interests regarding death?
Right.
Think about how society treats 12-year-olds in literally every other legal arena. You don't let a 12-year-old buy a lottery ticket. You don't let them drive a car. You absolutely do not let them sign a binding financial contract.
Because of brain development.
Exactly. Neurologically speaking, their prefrontal cortex, the part responsible for complex decision-making and long-term consequence assessment, is decades away from being fully formed. Science tells us it doesn't finish developing until the mid-20s.
And yet the system asks them to comprehend the absolute finality of non-existence.
Yes. And worse, how can a child make a truly voluntary choice when the adults in the room, the doctors in white coats, the exhausted parents, are framing this lethal injection as compassionate medical treatment? The power dynamic alone makes uncoerced autonomy virtually impossible.
You're outlining a profound psychological dilemma. When you evaluate a vulnerable minor, you have to factor in their primary psychological drivers.
Yet wanting to please their parents.
Exactly. Often a child's deepest instinct is to alleviate the distress of their caregivers.
Right.
If a chronically ill or deeply depressed child senses that their suffering is emotionally or financially destroying their family, their request to die might not be about personal autonomy.
It could be an act of tragic self-sacrifice.
They might be asking to die to save their parents. Yet the law struggles to measure emotional nuance. It views this strictly through a clinical lens, focusing on the cessation of pain.
And it places this astronomical moral burden on both the evaluating doctor and the parents holding the pen.
Yes.
And when a legal framework allows highly subjective criteria like unbearable suffering to be cured by death, it doesn't stay confined to clear-cut cases. It inevitably bleeds into new territory.
It expands.
Right. If subjective distress is enough, what stops the system from expanding to include people whose suffering is generated entirely by how society treats them? That brings us to a clinic in The Hague.
The Dr. Vandenberg case.
Yes. Dr. Vandenberg is sitting in his office, rubbing his eyes. The fluorescent lights above him are humming this erratic B-flat, and on his desk is the thick medical file of a patient named Bram.
24-year-old man.
24. He had been diagnosed with severe autism and mild intellectual disability. Looking through the charts, Vandenberg notes what was absent. Bram didn't have a terminal tumor. His lungs were clear.
He was physiologically healthy.
Incredibly healthy. His heart was beating with the steady rhythm of a young man with decades of biological life ahead of him. Yet Bram's application for euthanasia had been submitted, and it fell squarely under the legal definition of unbearable suffering with no prospect of improvement.
And why was that?
Because Bram simply couldn't navigate the sensory violence of the modern world. He couldn't decipher the unspoken social codes that neurotypical people download at birth. Sitting in that sterile office, Bram looked directly at the doctor and just said, "The world is too loud, doctor."
Wow. Just a flat statement of fact.
Entirely flat. No manic despair, no theatrical grief. And Vandenberg looked at the rising charts of similar cases across the Netherlands, and a sickening realization hit him.
That he wasn't eradicating a disease.
Right. By signing this euthanasia form, he was merely rubber-stamping society's failure to accommodate its most fragile minds. It wasn't Bram's condition that was incurable, it was the world's patience.
And that realization is painfully supported by the empirical data. To understand the scale of this, you have to look at an investigation published by the Cambridge University Press.
What did they find?
Researchers reviewed 39 Dutch case reports spanning from 2012 to 2021. They specifically isolated cases involving patients with intellectual disabilities, ID, and autism spectrum disorder, ASD.
And the statistics are pretty unsettling.
Very. Of the cases reviewed, 49% of the patients had an intellectual disability, and a staggering 62% had autism spectrum disorder.
But I need to stop you there because we need to be incredibly clear on the terminology for the listeners. Autism and intellectual disabilities are not psychiatric illnesses. They are not degenerative diseases.
Right.
They are lifelong neurodevelopmental states. They are part of the fundamental wiring of the brain.
Exactly. And that distinction is precisely where the application of the Dutch criteria becomes highly controversial.
Yeah.
When the researchers broke down the exact causes of unbearable suffering cited by the doctors in these cases, the reasons were largely social and environmental.
They weren't describing physiological pain.
In 77% of the cases analyzed, the primary cause of suffering cited was social isolation and loneliness.
77%, just from loneliness.
Yes. In 56%, the doctors cited a lack of resilience or an inability to cope with the modern world. 44% pointed to rigid thinking or an inability to adapt to change.
And what about the sensory aspect?
26% specifically cited oversensitivity to stimuli, exactly like Bram, finding the world too loud.
If you were listening to those percentages, you realize they're essentially just describing the standard diagnostic criteria for autism itself. They're taking the fundamental traits of being neurodivergent and classifying them as fatal symptoms.
To make this tangible, take a specific case documented in the study. It involved a woman in her 70s diagnosed with autism. She underwent a standard, successful gastric bypass surgery.
Okay, to improve her physical health.
Right. But after the surgery, the strict medical requirement was that she had to eat very small meals several times a day. However, because of the rigid thinking and reliance on fixed routines associated with her autism, she was cognitively unable to adapt.
She had always eaten 3 large meals a day.
Her entire life. And she could not break the routine. Her inability to adapt led to severe malnutrition and, effectively, starvation.
So instead of finding a creative way to accommodate her neurodivergent needs, what did they do?
The medical establishment looked at her situation through the lens of the euthanasia framework. They classified her inability to adapt as unbearable suffering with no prospect of improvement. She was granted euthanasia. In fact, the researchers noted that in 1/3 of all the autism and ID cases reviewed, the physicians justified the no prospect of improvement criterion simply by stating that autism and ID are lifelong, untreatable conditions.
They used the permanence of the disability as the legal justification for the permanence of death.
It's a huge shift.
I want you to really think about the implications of this data. If 77% of these patients are getting a lethal injection because their primary symptom is social isolation, we were taking profound societal failures and rebranding them as incurable medical conditions.
We're medicalizing social issues.
Exactly. If someone wants to die because they are chronically bullied or excluded from the workforce and our institutional response is a lethal injection, isn't that a tacit, state-sponsored endorsement of disableism?
This raises an important question, and it's the exact point being fiercely debated globally. Experts like Professor Tim Stainton have exhaustively reviewed this practice and drawn chilling historical parallels.
What kind of parallels?
He, along with other critics, has publicly compared assisting people with autism and ID to die to a modern form of eugenics. The argument is that this system disproportionately targets vulnerable populations who desperately need tailored social support, not state-sanctioned death.
They need inclusive community building and occupational therapy.
Right. Critics argue the system chooses the cheaper, permanent solution of death over the expensive work of societal inclusion. But on the other side, you have the counter-argument from the executing physicians themselves.
What's their defense?
It's rooted in immediate pragmatic empathy. They argue they are clinicians, not social engineers. They can't write a prescription for a more accepting society or legislate away bullying.
So they focus on the immediate pain.
When a patient is experiencing agonizing psychological pain today, the physician argues they have a moral duty to treat the suffering with the tools the law provides, rather than forcing the patient to wait for society to miraculously reform.
It's a tragic, inherent limitation of the medical model. If the only tool you have been given by the state is a syringe, every complex social problem starts to look like a terminal disease that requires an injection.
That's a very stark way to put it, but accurate.
And this philosophical shift blurring the lines between physical pathology and social despair isn't just an isolated European phenomenon. To see where this logic leads, let's shift over to North America.
The Canadian system.
Right. Picture a brightly lit clinic in Vancouver. Dr. Eliana Ross looks down at the syringe resting on the stainless steel tray beside her. It looks perfectly mundane, identical to routine sedation medication.
Just a clear liquid in a plastic barrel.
Exactly. Yet its contents dictate an absolute conclusion. Her patient today is Evelyn, 62 years old. Physically, Evelyn's chart is perfectly healthy, no cancer, no organ failure.
But she's suffering.
Evelyn is being crushed by severe treatment-resistant psychological trauma, a lifetime of emotional agony. And crucially, this trauma has been recently compounded by a brutal eviction notice she couldn't afford to fight.
And under local laws, that mental anguish qualifies her?
Yes. Evelyn looks up from the bed at Dr. Ross and smiles. A genuine, relieved smile. She whispers, "You're the only one who didn't tell me to just keep fighting."
Wow.
Eliana feels a cold sweat bloom beneath her scrubs. The paperwork is flawless. This procedure is codified in her country as the absolute pinnacle of compassion. Yet the paradox is howling in the room.
The state wouldn't fund her housing.
Exactly. The state found it too difficult to fund Evelyn's supportive housing or psychiatric care, but engineered a flawless, publicly funded system to manage her death.
Evelyn's story perfectly encapsulates the rapid evolution of Canada's medical assistance in dying laws, universally known as MAID. The Canadian legal journey is the starkest case study in modern history of how quickly these boundaries can expand.
How did it start? It wasn't always this broad, right?
The original MAID law was passed in 2016. At that time, it was designed with relatively strict boundaries. To qualify, a patient had to be suffering from a grievous and irremediable medical condition.
Okay, that sounds fairly standard.
But the crucial anchoring phrase in the 2016 law was that the patient's natural death had to be reasonably foreseeable. The law was primarily envisioned for people in the final stages of terminal illnesses, like end-stage ALS or metastatic cancer.
Right. So the original 2016 framework was focused on proximity to natural death, minimizing final physical agony.
Exactly. But the legal landscape shifted seismically in 2021 with Bill C-7. The government passed a massive expansion that fundamentally altered the law's philosophical core by explicitly removing the requirement that death be reasonably foreseeable.
Meaning you didn't have to be dying anymore.
Right. This created what is known as Track 2 MAID. Overnight, patients with chronic conditions or physical disabilities, people who might otherwise live for decades, could be legally euthanized if they deemed their suffering intolerable.
And the expansion didn't stop there, did it?
No. The legislation also included a planned expansion to eventually include mental illness as a sole underlying medical condition for MAID.
Just so we are crystal clear on what that means. Someone with severe depression or PTSD, who has absolutely zero physical ailments and decades of life left, could legally request state-assisted death based solely on a psychiatric diagnosis.
Yes, that is the exact legal trajectory. And removing that reasonably foreseeable requirement has already led to cases that triggered massive international outrage.
Like the Alan Nichols case.
Exactly. Alan Nichols was a 61-year-old Canadian man who was deaf and used a cochlear implant. He had a history of depression and was hospitalized during a severe psychiatric crisis.
And while he's in the hospital in crisis, he asks for MAID.
He submitted a formal request citing hearing loss as his primary medical condition, causing intolerable suffering.
And his family, what were they doing?
His family was devastated. They argued vehemently to the medical staff that he was not of sound mind, that he was in a temporary treatable episode, and obviously did not have a foreseeable death.
But the doctors approved it anyway.
They evaluated his request, approved it under the expanded laws, and euthanized him.
That is horrifying to imagine. If you put yourself in the shoes of that family, you are screaming at the hospital administration that your brother needs psychiatric help, and the state's response is to legally process his lethal injection.
It highlights a devastating disconnect, and it creates a profound conflict within the medical profession itself. You have to consider the Hippocratic Oath, which explicitly states doctors shouldn't administer poison or counsel anyone to do so.
The historical mandate is to preserve life.
Right. But under Canadian law, this ethical stance is actively challenged. If a doctor has deep moral objections to performing euthanasia, they can't just walk away.
What do they have to do?
They are legally required to provide an effective referral. The objecting physician must actively transfer the patient to a doctor or agency who will perform the procedure.
Which makes them complicit in the act from their perspective.
Exactly. Many doctors argue that forcing them to arrange the death under threat of losing their medical license forces them to aid and abet an act they consider morally unconscionable.
I want to give you an analogy to help visualize what is happening here on a systemic level. If a massive suspension bridge is crumbling, and pedestrians are terrified of falling into the river, the state's response shouldn't be to offer the pedestrians a parachute to jump off safely.
They fix the bridge.
You fix the damn bridge by offering MAID to people suffering from poverty, eviction, disability, and mental anguish. Are we just giving vulnerable people parachutes instead of fixing the social safety net?
That's a very powerful way to frame it.
If the government refuses to fund a wheelchair ramp or psychiatric care, or affordable housing, but they will swiftly pay for a lethal injection, the concept of free choice is an absolute illusion. The choice to die is violently coerced by a system that refuses to help you live.
And that is precisely the core argument championed by disability advocates. They argue that when the safety net systematically fails, MAID ceases to be medical compassion and becomes a dystopian form of economic relief for the state.
Because it's cheaper.
It is cheaper to euthanize a complex patient than to house and treat them for decades. Now, to understand how different legal philosophies approach this exact fear of coercion, we need to look at the United States.
Right, because when you look at the U.S., the entire philosophy, the rules of engagement, and the terminology change completely.
In the United States, the legal practice is formally referred to as medical aid in dying, or MAID, or physician-assisted suicide. It is explicitly not euthanasia.
That distinction is huge.
It is the defining barrier. Euthanasia, where the doctor actively administers the lethal dose, like pushing a plunger, remains strictly illegal in all 50 states. It's considered homicide.
So what is the doctor's role in the U.S.?
The physician's role is strictly limited to evaluating eligibility and prescribing the lethal medication. The patient must be physically and mentally capable of self-administering the dose.
Usually by drinking it, right?
Usually a prescribed barbiturate solution. If the patient's disease progresses to the point where they cannot physically lift the glass and swallow it, the procedure cannot legally happen. No one else can pour it down their throat.
That physical requirement of self-administration is a massive, intentional, legal barrier. It guarantees the final act rests solely with the patient.
It guarantees pure, unassisted autonomy. And the journey to establish this framework in American jurisprudence has been long and controversial. Historians note debates over this in state legislatures like Ohio as early as 1906.
But it really exploded in the 90s, didn't it?
It did, largely due to Dr. Jack Kevorkian. He became infamous for actively assisting over 40 people in dying. A pivotal case occurred in 1990 with Janet Adkins.
She had Alzheimer's, right?
Yes. early onset Alzheimer's. Before she lost her cognitive faculties, Kevorkian helped her die using a suicide machine he invented, which allowed her to push a button that delivered lethal drugs.
And he wasn't convicted for that?
Initially, no, because Michigan had no specific laws outlawing assisted suicide at the time. But Kevorkian pushed the boundary further. In 1998, he videotaped himself actively giving a man named Thomas Uke, who suffered from ALS, a lethal injection.
He crossed the line into active euthanasia.
He did, and he dared the authorities to act by airing the tape on 60 Minutes. He was subsequently indicted, convicted of second-degree murder, and served 8 years in a maximum security prison.
He practically forced the legal system's hand to define the absolute boundaries.
He did, and the definitive boundary for the country was set by the Supreme Court in 1997 in the landmark case Washington v. Glucksberg. Doctors argued that the 14th Amendment's Due Process Clause should include the right of a terminally ill adult to seek assisted suicide.
And the Supreme Court said no.
They ruled unanimously against them. Chief Justice Rehnquist argued the state has a profound interest in preserving human life and protecting vulnerable groups. However, while there was no federal constitutional right, they left the door open for individual states to decide.
Which leads to the patchwork we have today.
Right. As of 2026, 14 U.S. jurisdictions allow it. Oregon was the pioneer in 1994, though implementation was delayed until 1997. Since then, states like California, Colorado, Washington, Illinois, and New York have passed their own laws.
But compared to Canada and the Netherlands, these 14 state laws are incredibly restrictive.
The patient must be an adult, deemed mentally competent by multiple physicians, so advanced dementia disqualifies you. And most importantly, they must have a terminal illness with a medically verified prognosis of 6 months or less to live.
So no track 2 for chronic suffering or mental illness.
Exactly. However, there have been recent legal shifts. In 2022 and 2023, Oregon and Vermont settled lawsuits that challenged their residency requirements. They legally removed them, meaning out-of-state individuals can travel there to access medical aid in dying.
But that creates terrifying legal complexities if they take the medication back home.
Oh, immense complexities. If a patient legally acquires the medication in Oregon but travels back to their home state, where assisted suicide is a felony, anyone who helps them mix the dose or is even present could face serious criminal charges like manslaughter.
Interesting. Even with these incredibly strict guardrails, the 6-month prognosis, the self-administration requirement, disability rights organizations in the U.S. still fiercely oppose these laws.
Groups like ADAPT and Not Dead Yet.
Exactly. They fight these bills tooth and nail. Why? Because they look at the stark reality of systemic inequalities in American healthcare. If you're a disabled person and you can't get Medicaid to cover an expensive specialized wheelchair or in-home care,
but that same insurance will seamlessly cover a $300 lethal prescription.
Yes. The choice to die is inherently coerced by poverty. Furthermore, these advocates point to the Werther effect. It's a sociological phenomenon named after an 18th century novel referring to the social contagion of suicide.
When suicide is highly publicized, rates in the surrounding population rise.
Right. Advocates argue that normalizing suicide as a valid medical treatment for physical decline inadvertently signals to disabled people that physical dependence makes life fundamentally not worth living.
It creates cultural contagion that devalues disabled lives.
Yeah.
Sure. The desire for individual autonomy at the end of life versus the state's duty to protect vulnerable citizens from systemic coercion.
But there's a glaring blind spot in all of these systems, whether it's the Dutch model or the U.S. laws. They all assume the suffering patient is capable of navigating a clinic.
That there are doctors to consult and forms to sign.
Right. But what happens outside the sterile environments of hospitals? What happens in the shadows, inside private homes, when desperate family caregivers take the law into their own hands?
That brings us to the tragic reality of vigilante caregivers.
Like the case of Bonnie Liltz in Illinois, Bonnie was 56 years old and the sole 24-hour caregiver for her adopted daughter, Courtney.
Courtney had severe cerebral palsy, didn't she?
Profound cerebral palsy. She was 28, entirely dependent on her mother. Bonnie fed her through a gastric tube, bathed her, lifted her out of bed. Everyone described Bonnie as a fiercely loving mother, but then the crisis hit.
Bonnie got sick.
She was diagnosed with cancer. During her prolonged hospitalization, she was forced to place Courtney in a state-funded nursing home. And Courtney suffered terribly there. The facility just wasn't equipped for her intense needs. She was neglected and miserable.
So what happened when Bonnie got out?
Her health was shattered. She faced an impending colostomy bag surgery. She looked at her declining health and believed with absolute certainty that once she died, Courtney would be permanently abandoned to a system that would let her suffer.
She was driven entirely by despair.
Complete despair. So Bonnie ground up a massive overdose of prescription medications. She administered the lethal cocktail to Courtney through her feeding tube, and then Bonnie took an overdose herself.
But Bonnie survived.
Miraculously, yes, but Courtney did not.
From a purely legal standpoint, if you look at the criminal statutes, this is a homicide. There's no ambiguity. In a deeply researched paper titled Compassionate Homicide, legal scholar Michelle Buchanan-Raphael breaks down how the justice system handles these impossible cases.
Because the law doesn't care why you did it.
Right. Under black-letter criminal law, the core elements are the actus reus, the guilty act, and the mens rea, the intent. The underlying motive driving the intent is entirely irrelevant.
So killing your disabled daughter out of a misguided sense of mercy is treated the same as killing a stranger for insurance money.
Yes. There is currently no recognized legal defense of compassion. You can't claim self-defense because the disabled victim posed no threat. You can't claim the necessity defense, the idea that you broke the law to prevent a greater harm.
Because the law never views killing an innocent person as a lesser evil.
Right. And you can't claim provocation or heat of passion because the victim's illness is a blameless predicament. Therefore, a prosecutor has the legal right to charge a caregiver like Bonnie with first-degree premeditated murder.
Which often carries mandatory life sentences. But if you are listening to this, that probably feels fundamentally wrong. The moral culpability of a desperate, cancer-stricken mother is obviously different from a cold-blooded killer.
Which is precisely why Buchanan-Raphael proposes profound legal reform. She argues for the creation of a formal, codified partial excuse of compassionate homicide.
So it wouldn't be an acquittal.
No, the act remains unlawful, but it would formally mitigate the charge from first-degree murder down to manslaughter. It functions theoretically like the heat of passion doctrine.
What's the theoretical basis for that?
It relies on what's called the lack of fair opportunity to conform one's conduct to the law. The defense argues caregivers like Bonnie are placed in utterly untenable, socially isolated situations.
The crushing toll of 247 caregiving combined with the failure of the state to help.
It pushes them to a psychological breaking point. They experience a reasonable, intense, emotion-profound compassion and terror for their loved one's future that overwhelms their rational judgment.
So, because the criminal code currently doesn't have a legally defined box for this, what actually happens in courtrooms right now?
What we see in practice is a systemic phenomenon scholars call unprincipled mercy. Because the black-letter law is so draconian here, juries, judges, and prosecutors often take matters into their own hands off the official record.
They quietly bend the rules.
Yes. Prosecutors will quietly offer heavily reduced plea deals for involuntary manslaughter. Judges will issue shockingly lenient sentences of probation instead of mandatory prison time because they deeply empathize with the caregiver's unimaginable burnout.
Which is what happened to Bonnie Liltz. A judge initially gave her probation.
Right. But because this mercy is discretionary and hidden, it creates terrifying inconsistencies. One caregiver gets probation, while another in the next county facing the exact same circumstances gets charged with first-degree murder and spends their life in prison.
But wait, if you are looking at this logically, we have to examine the sharp counter-argument here. Let's look at it from the perspective of the victim, who is entirely silenced in these proceedings.
It's a critical perspective.
If we formally change the legal code to reduce the penalty for killing a disabled relative, if society codifies a law that says it is murder if you kill an able-bodied person, but it is only manslaughter if the victim was severely disabled, doesn't that legally declare that a disabled person's life is inherently worth less?
That's the ethical nightmare.
How do you balance the desire for mercy for a desperate mother against the fundamental right to life of the victim? A victim who, in Courtney's case, had absolutely no ability to consent to her own death or object to the poison in her feeding tube.
It is the ultimate, perhaps unsolvable collision of human empathy and constitutional justice. When you step back and view all these frameworks together, we're looking at a vast, turbulent spectrum of how modern society attempts to deal with unbearable suffering.
It's just staggering when you zoom out.
On one end, you have the Netherlands, where the state medically administers deaths to individuals with autism, effectively defining profound social isolation as a terminal condition. Then you have Canada, rapidly expanding its legal apparatus to offer lethal injections for poverty-exacerbated trauma and mental illness.
forcing doctors to navigate the moral ruins of the Hippocratic Oath.
Exactly. And then you have the United States desperately attempting to maintain strict terminal illness boundaries, yet facing fierce opposition from disability rights groups, terrified of systemic coercion within a privatized healthcare system.
And finally, the shadowy realm of vigilante caregivers,
where desperate family members resort to violent acts of mercy because the social safety net has entirely collapsed, leaving the criminal courts to uncomfortably bend the ancient laws of murder.
As our technological ability to endlessly prolong biological life continues to advance, it has vastly outpaced our social infrastructure's willingness to make that extended life bearable. The ultimate legal and moral battles of the 21st century will not just be fought over who has the right to live, but over who holds the absolute authority to define when a life has lost its meaning.